What happens when the surface infection of the conjunctiva actually penetrates down to the cornea? You now have what is referred to as keratitis. Okay, keratitis is actually an infection of in the cornea itself. The conjunctiva, if it's damaged, if it's cut, can repair it, and for the most part, those repairs will also be clear cells, so that way light can penetrate, pass through. Damage to the cornea? No. Damage to the cornea, for a lot of time, for most parts, could lead to scarification of the cornea. You accumulate enough scars of the cornea, you will impede light passing through, which means that patient will now, for all intents and purposes, be blind. Causative agents here, some bacteria. Herpes, again, is going to be one of our agents of choice. What happens here is oral herpes. And I do have a side note, I have a problem with your textbook automatically saying HSV1 here. Human simplex virus 1. Everyone always says, oh, this is oral. Yeah, no. Back 80s, 90s, we're starting to see the beginning of a flip. During the Clinton years, or after the post-Clinton years, we saw a real big flip here. Depending upon who you read, anywhere from 20-25% of the oral's herpes, or herpes sores or herpes infection around the mouth, is herpes simplex 2, which we traditionally used to think of as genital. And down there in the genital region, 20-25%. The opposite number, herpes simplex 1. Okay, look, to be blunt, it's the oral sex. Okay, oral sex has caused the flipping here. So when they say simplex 1, okay, take that with a grain of salt. Okay, now thing is, whether simplex 1, simplex 2, from a clinician standpoint, doesn't matter. Treatment's still the same. But for them to sit there and just flat out state it's simplex 1 here, simplex 2 there, no. Okay, reality is not quite that cut and dry. Anyways, what you see here is instead of the herpes virus traveling down the trigeminal nerve, the mandibular branch of the trigeminal nerve, okay, goes down along the jawline, and the reason why it's always around your mouth or your nose is because that's the terminal end of the mandibular branch or terminal end of the trigeminal nerve it's traveling down. For some patients, though, you'll see that it will hop branches and will now go up what is referred to as the ophthalmic, up towards the eye. And it'll start traveling that way as it gets closer and closer to the eye until you're going to end up with the herpes vesicles either at or near the edge of one of the eyelids, which is now every time you blink, you're now wiping it across the conjunctiva. It's going to penetrate. It's now going to get into the cornea. So that's if the patient already has herpes. The last bullet there where they're talking HSV2, again, I have a problem with them just flat out stating this way, but they've also had clinical reports of people being exposed during sexual encounters. Okay, they touch somebody else's genitals and they wipe their face. They're now wiping herpes on their eye, and that's how they get the herpes vesicles there now. However it gets there, not going to worry about. What we're going to look at, though, is we need to diagnose it. You need to diagnose it as quickly as possible so you can start treatment. Acyclovir, great. Remember we talked about that in a previous lecture in this chapter. and or trifluoridine. Okay, both of these are going to be antivirals that are going to interfere with viral replication. So you're not going to get rid of the infection, you're just going to minimize outbreaks. You're going to try to increase the time interval between outbreaks. Because remember, this is the thing with herpes. It's a latent infection that pops up every so often. Some people, cold sores, whatever, once a month. Other people, once a season, once a year, once a decade. Okay, so by using these treatments, you're not going to get rid of the infection. You're just trying to prolong the interval between outbreaks. Then you also have the Acanth amoeba keratitis, that story I just told in the last lecture. Okay. Problem with people wearing contact lenses used to be. Now it's associated with people who wear their contact lenses and they go swimming. Woohoo! The pond water, lake water, whatever, gets caught between the contact lens and the conjunctiva. You're trapping amoeba there for a while. Gives them the ability to get going. For people who don't wear contact lenses, this still could be an issue. You get water in your eyes. Less of a problem though, because you immediately start blinking, tears start rinsing away, so the chances for non-contact wearers is greatly reduced compared to those who do wear contact lenses. And the chances of people getting this keratitis due to Acanth amoeba because they're swimming in a pond or whatever, that's already quite low to begin with. So it's not one of those, oh my God, you're going to see this every week type things.